Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you another interview from a presentation given at the 2019 AAOMPT Conference. Our guests today are Dr. Brian Swanson and Dr. Sean Riley. Dr. Swanson received his degree in physical therapy from Quinnipiac University and earned a Doctor of Science from Andrews University. Dr. Swanson is a board-certified orthopedic clinical specialist and completed a 2-year residency and fellowship at the Institute of Orthopedic Manual Therapy in Woburn, Massachusetts. He is currently a faculty member at the University of Hartford, as well as the Select Medical Orthopedic Physical Therapy Residency Program, and has worked with multiple fellows in training as part of the AAOMPT fellowship process. Dr. Sean Riley first graduated from the University of Connecticut Physical Therapy Program, and then completed a doctorate in physical therapy from Simmons College. He went on to complete a second doctorate, a Doctorate of Science, from the Texas Tech University Health Sciences Center. Dr. Riley is also board-certified in orthopedics through the American Board of Physical Therapy Specialists and has completed a sports certification as well. In addition, he completed certification in orthopedic and manual therapy in the extremities through the International Academy of Orthopedic Medicine, U.S., and a fellowship in manual therapy through Regis University. Without any further delay, let's move on to the interview. Dr. Riley, welcome to the podcast. How are you doing today?
I'm doing great. Thanks for having us.
You said us. That means we've got a second person here with us. You are joined today by Dr. Swanson, who we also know from episode 4 on the podcast. Dr. Swanson, how are you doing?
Oh, fantastic, thanks. And happy to be back on the podcast.
We are happy to have you back. And today, as I'm sure you're aware, is a topic that's similar to the one covered the first time you were here. You and Dr. Riley are here today, in fact, this weekend for the AAOMPT annual conference for 2019. And you're presenting on a topic titled Precision Physical Therapy, Application of Patient-Specific Treatment via Provocation and Alleviation Testing and Purposeful Communication. One of the reasons we picked this for the podcast is that it has to do with precision. That's what we try to strive for in the academy. It's always better for us, the patients, the payers, for everyone involved when we are better and more precise at what we're doing. As we begin to jump into things right now, one of the things that caught my eye in the description of the presentation you're going to give is that you're talking about, or you mentioned, that the physical therapy profession seems in some ways to be moving towards a more generic or one-size-fits-all approach. Can one of you start us off right now with your general thoughts on why that is, how it's going, maybe perhaps what's the problem with it? Which, of course, leads into the general point of why you're giving this presentation this weekend.
Well, many of our treatment paradigms that we're seeing more recently based on movement are meant to classify people into specific categories and then match a treatment to that individual within that category. The challenge is these systems assume that the individual sitting in front of us is going to fit into that classification system, which can be a challenge and may create less precision in our ability to match what's going on with the patient with a specific treatment for them.
I think if we take that one step further, if we look at the evidence that's out there on our current treatment-based classification schemas, there's published literature saying that, as many as 50% of patients don't match any one criteria or any one category. And, especially I think for the younger physical therapists out there, they're left with, the end result of saying, put them in the best fit category and try to make them fit. And it kind of reminds me, there was this, battery commercial a number of years ago. It was two brothers, and one of them was trying to pound the square peg into the round hole. And the second brother said, that's okay, just hit it harder. It'll go, it'll fit. And, I think that's what we do with our patients a lot. And we say, we have these systems, and so now our patients must fit. And I think particularly for the younger therapists, if that's all they've been taught, then we're going to get a very generic one-size-fits-all therapy based on, some classifications that might not match up our patient presentation. And so, our hope this weekend is that we'll be able to present some different models that will, kind of work across different philosophies, across different systems to be very patient-specific and patient-focused while still being reliable and useful.
Hearing you give that description reminds me, and I don't think this is what either one of you were referring to, but perhaps some horrible flavor of it. When I was in my final clinical placement for PT training, I had a pretty good pick in the lottery, and I ended up at what was supposed to be what was a very well-respected orthopedic outpatient clinic. And they had this whole system of, I guess they were like little cubbies or mailboxes, and they had labeled them knee, shoulder, hip, neck, basically just a list of all the body parts. And I was basically trained to pick the knee exercises. And if you have knee pain, these are the exercises that somebody with knee pain completes. And same thing, it was all cookie cutter. It was as bad of a one-size-fits-all approach that you could possibly imagine. And, that's how I was sent into the profession to take care of patients. So, having come a long way from that, it's exciting to see seasoned clinicians and academics such as the two of you here to present this type of content.
It's interesting you say that about the one-size-fits-all exercises. And, as we think about that, Dr. Riley and I recently published a systematic review on different movement-based classifications for chronic back pain. And as we think about our spine patients, our high-level evidence so far tells us that general exercise is just as useful as many of these movement-based classification schemes that we have out there. And, when we really stop and look at it, we have to ask ourselves why. And part of it is that some of our systems are based on things that are less than reliable. Most of them are operator dependent. I think, I thought, I saw, or felt, as opposed to patient-specific factors where if I can reproduce somebody's symptoms very specifically with a mechanical stress, and I can alleviate their symptoms with some other variety of stress, then, on a patient-specific N-of-1 basis, that should lead me in the direction of where I need to go. And rather than being operator-dependent, it takes us in the direction of being patient-specific.
So our thoughts are related to generating a reasoned process. So if we look at how we go about the scientific method, you generate a hypothesis, you test the hypothesis. If the hypothesis is true, you verify it. If it's not true, you formulate a different hypothesis. You don't generate a hypothesis, test a hypothesis. If it's not true, we're going to test that again. Still not true. We're still going to. So some of these systems, what they do is they come up with the answer before they even identify what the question is.
Those are both excellent clarifications. And obviously, as a manual physical therapist, I'm using exercise in the clinic all the time. And I see how sometimes just getting people moving is, it's a form of medicine. Not all of that, of course, is a topic for today, but, people know the neurophysiological effect. They know the general impacts it has. And certainly we need things from all these different worlds. And Dr. Riley, I think you just started to go into the topic that was going to be my next question. One of you two, I can't remember at this point, previously mentioned how some of this is relatively universal. I think, Dr. Swanson, you mentioned that. And you want to present content that isn't just in this one school of thought. Even if we all do things somewhat differently, there is an overall process. That's the testing, the hypothesis, the prove or disprove what you previously had concluded. Can you talk a little bit more about what those general elements are that every manual physiotherapist can take from a presentation like yours and then implement in the clinic?
I think if we started on from a patient-centered focus, we all have to accept that every patient has some element of a nociceptive driver to their pain. Most patients that we'll see, is particularly in spine practice, we may have some element of a peripheral neuropathic pain. If anybody has any sort of chronicity to their problem, they have some element of central sensitization. One of our problems as a profession is we've siloed those three thoughts. Am I treating the nerve? Am I treating the nociceptive problem? Or am I treating the thing between the ears because it's sensitized? As opposed to saying every patient has all three elements. We have to acknowledge all three elements and decide which piece is the biggest driver of the ship. And if we take those elements as one framework that we know we can identify fairly reliably from the previous research, and then we put it in the patient-specific factors where we can say, for every one of these issues, there's going to be some mechanical factors that for every patient we can modify, and that being loading on the structure, tension or stretch on the structure, and the position that we put it in. And if we work with load, position, and tension as different things that we can modify as we drive our treatment, in the construct of nociceptive, neuropathic, or central sensitization, we should be able to say we can change most things, and we should be able to identify most problems for the patient on a very specific basis in a way that should be meaningful to them as we try to relate it to daily life.
So we kind of think of this as a unifying theory. So we're talking about there's challenges with these other classification systems. The problem is using them for classification and treatment. The premises of them may be strong in the context of an N equals 1 and within the context of generating a hypothesis. The challenge then becomes, if you test it by providing them with an intervention that should get them better, if the hypothesis is true and it doesn't happen, you need to form another hypothesis. And that's really the challenge with just going down one path. It's not a linear process. It will change within and between treatment sessions. So if we just describe one iteration of it, taking it from start to finish, there has to be some other endpoint in order to restore somebody to independent function. So it just can't be, we started at A, we got to B, and we're done. So within this context that we're talking about, it continuously happens within and between treatment sessions.
So one way to think about that, of course, is that you're constantly thinking, you're constantly adjusting, you're constantly redirecting your pathway so that you can be on target.
Yeah, I think, applying the concepts within a test, treat, retest model with continual ongoing assessment and clinical reasoning is our best way to go about taking care of the individual patient. And, our challenge being that with some of our treatment-based classifications where then the treatments become very prescriptive, some of that reasoning goes out the window. It's supposed to be done for us. And we look at it and say, well, if we see these signs, then we do this. And then if that doesn't work, we have to take a big left turn somewhere. And, in a perfect world, it should be a U-turn and go back to your evaluation and say, what didn't I look at? What should I look at? What patient-specific factors did I miss that may have, driven this presentation that I can go look at again? And, that is, hopefully the content we're going to cover this weekend that the clinician can take with them back to the clinic on Monday and start to apply to patients.
So one of the quotes that we kind of framed our talk around was by Jeffrey Maitland, and I'm going to absolutely butcher this quote, but it's something along the lines of, if you go through and provide somebody with an intervention that should get them better and they don't get better, you're wrong. Because the patient can't be wrong. You have to come up with something else. You have to come up with a new hypothesis.
I think the second kind of sideline as we think about this in terms of the different hypotheses and the things that we've prescribed so far, what we've realized is that our TBC works pretty well in the construct of acute back pain, if we're going to stay in the low back realm here. And, part of the challenge is we know that most acute back pain gets better fairly irregardless of what we do. And, once we get into subacute, the evidence isn't as strong. And once we get into chronic, the evidence is kind of gone for it. And one of the pieces that gets lost in the implementation of our classifications, and I think some of our prediction rules and some of our other things that give us prognostic factors, is the understanding of some of the background knowledge, what happens with chronicity, what happens with degeneration, and the different changes that happen structurally that then predispose people to not respond to the groups that they might match from a clinical exam perspective for a TBC. And, the application of our background knowledge really should be the framework of our clinical reasoning and the thing that we base a lot of our decisions on. And, when we try to shortcut past that step, that's where we get our, between third and half of patients who don't match criteria or who don't respond favorably the way that we think they should.
So one of the things that pops into my head listening to this is just the general notion of patient expectations. And to give you an example, a question that I get asked pretty much every day, and an answer that I give back every day is, how often, how much, fill in whatever question you want. When should my second visit be? How quickly do you want me to come back? How many minutes should I stretch this tissue that you've taught me to stretch? And my initial answers are always, I don't know. I tell the patient very blatantly, well, here's what I know about you. You came in and described problem A. When I physically tested you, I found what I think is consistent with problem A. And I just did an initial treatment on you while you're here on day 1. And it was favorable. Let's say, just for the sake of the conversation, they got 20% better. But I still don't know how they're going to feel tonight, how they're going to feel tomorrow, how they're going to feel the next day. If they're sore for 3 days, if they never get sore, those are completely different scenarios. So I use it as a way to, basically tell my patient, I don't know. I will know more when you come back and give me more info. And it sets up a situation where they don't expect me to be perfect. 2, they're involved in the process, because they know that they have to participate for me to help them the most. And then 3, I find that it just makes the overall process more effective and efficient because it sets that expectation that we're going to work together and that I don't know where it's going until it goes there.
I think you hit on a few different points there that we could try to address as we go forward. I think first and foremost, the how much, how often question. If we're not stepping back and assessing severity, irritability, nature, and stage on every patient before we put our hands on them, we haven't done our jobs. And we haven't thought about what we're going to do, and we haven't, realistically tried to assess the expected outcome to optimize our result. And I think that's one of the first things we have to keep in mind, as manual therapists as we try to work through this process. I think the second question of expectation, that one's a little more nuanced. And we know that we can change expectation by what we tell them. And if we use the right words, we generate a more positive expectation. If we use more neutral and negative tones, we know that we can make their expectation less favorable. And I think anytime we get in that context, part of our job is to try to create as favorable an expectation as possible in the appropriate situations. When we think there should be a positive expectation, we need to really exemplify that for the patient. We need to be enthusiastic. We need to be very pointed in our directions. I think we have an obligation when we're not enthusiastic to be honest with them, even though I think some of our colleagues would tell us we risk, increasing catastrophic thinking, or we increase the risk of making a more chronic issue out of something by giving somebody a less than positive prognosis. We also know not everything has a positive prognosis, and we need to be honest with our patients. But, if we can take that expectation and, if we can somehow modulate that in a framework of a provocation and alleviation model, where I changed your pain or your pain changed, is probably a better way to say it, because I don't think we ever want to take all the credit for somebody's change. We identified it for them. We asked them what to do. But we saw your pain change when we used this test. And that tells me very favorably that there's something that we can change and you should expect to change. And then we can use that to drive expectation.
I think if we look at it as a system where we're going through and regenerating the hypotheses, we have a visual image of what this exam should look like if our hypothesis is true. And we're able to predict what is going to reproduce their symptoms, but more importantly, alleviate their symptoms, and then show them how they can potentially alleviate their symptoms and cross all of those check boxes and go across from this is the hypothesis, we tested it, it's likely true, we're able to make your symptoms better, you're able to make your symptoms better, and educating them, like you said, like this is a change based on immediate mechanical input. There's a delayed chemical response that may not happen until later tonight, the next day, that I just don't know where that is. I'm making a guess on your irritability, but I just, day one, I just don't know where that is. So I'm putting my toes in the water and I'm going to take it for a test spin. But when you come back, how did you feel later that night and the next day? I felt great. Now you have a place to start. If they had a certain amount of irritability after, you can either stay where you were, back off, make a decision. But it's a place where you can enter into the game so that you know the rules of the game and how you're going to play it moving forward.
I think one more piece to consider there as we talk about giving them the tools to control their pain. One of our great challenges as physical therapists is always dealing with patient self-efficacy. And if we want a patient to be more self-efficacious in their management, one of the best tools we have is symptom alleviation and showing them how they can control their pain. And giving them the ability to modulate their pain, their ability to get some pain relief when they haven't had previous relief, and using that as a means to really drive self-efficacy in their home exercise program so they get better carryover between their 2 sessions a week, those other 48 to 72 hours between sessions. Well, what happened in between when they come back and say they were sore? We can very clearly go back and say, how often did you try the alleviation exercise? How effective was it for you? And then we can use that to modulate our program as we move forward.
So there are 2 themes in here that you both keep hitting on regularly, and I want to dive a little bit into each of them, although, we could obviously spend entire, semesters talking about them. The first one is provocation and alleviation. Now, I'm not trained in every approach out there, but in terms of my background, these are words that are better known or more frequently utilized with certain approaches. So I'm assuming there are, some listeners who might not fully understand what you mean when you say that. Can you provide a brief description of exactly what this means and how you use these clinical principles to implement what you're doing in terms of testing?
I think, if we go back to, at the risk of being redundant, since we have recurrent themes already, go back to episode 4, we talked about provocation alleviation in the cervical thoracic spine. When we look at it, when a certain motion clearly reproduces somebody's pain, and we position their spine or their body in some other position opposite that motion, where we limit or restrict the motion to certain regions. And then we ask them to repeat the provocative motion, it no longer hurts. Right? That's an example where we provoked with the motion the first time, we alleviated it by blocking motion elsewhere. I think one of the really easy concepts to work with would just be compression distraction. If we say someone has a load-sensitive spine, if we do something like a Sperling's test, or if we load their spine manually and compress them, they have their pain. If we then do a distraction test or unload their spine and they get a relief of their pain, so we provoke it with the load and alleviate it with the distraction. And really all we're thinking about is, one motion or one movement that reproduces their concordant pain, and then something opposite that motion that alleviates it, or something that blocks the motion at one region to clear that region and implicate another.
I think we should also add, and I think it's important to think about irritability in this context. So we're talking about provocation and alleviation and connecting those dots. But in the context of somebody that's highly irritable, maybe symptom modification is a better term to use. So if somebody comes in and they're hyper irritable, are we going to use a provocation test? We're going to have maybe one shot at this today, and we need to make a choice, most likely on what's going to make them better to answer the specific clinically meaningful question, and then send them home with something that they can modify their own symptoms so that when they come back next time and everything is dialed down a little bit, now we can go into more detail and be more specific in our approach. So I think you really have to look at that aspect of irritability.
Yeah, so clearly there are multiple variables that we're juggling at the same time, which is going to get to my second question. But just in response to that, it makes me think of the earlier parts of my career in a time period in which I was basically taught to test lots of things, right? You don't know what to think until you have lots of test results. And then you eventually get to that point where you say to yourself, just like you pointed out, everything's going to be painful. Whatever I do, this patient...
Some of it's just noise.
Correct. Some of it's just noise. So I can do one or two things right now and hopefully get, some sort of positive outcome. But if I do everything, it's going to be all that noise. It took me a while to get there. I'm definitely there now. And, if I, 10 years ago looked at some of the evals that I write now, I would have thought to myself, what on earth do I do with this patient? There's no information here. But on the flip side, if I were to go back and read some of those other evals that I did 10 years ago, I would say the same thing. What do I do with this? There's so much information, I can't possibly process it. It's all meaningless.
I think you have to start at the beginning. So if you have all of this data, look at what is the most problematic for the individual. Ask them. So it's about not only collecting the data, but organizing and prioritizing. So what is the biggest issue for this individual? Or are there a number of issues? So in the case of, let's just say, swelling. So somebody has swelling. They're going to have limited motion. They're going to have pain. And they're going to have inhibition of muscle function. If I could address that one thing, I can cross 3 things off my list. So what is the biggest issue? And can I match to that in order to provide the biggest bang for the buck for that individual?
I'm going to refer back to a line that I use with my students now constantly, and at least for me, the credit for this line goes to Tony Roddy. She's the first one I heard say this to a group of PT students, and it's special tests are for special moments. We don't test to diagnose. We test to rule in and rule out once we've established our hypothesis. And I think that's sometimes a tricky concept for probably some of the more experienced therapists that are out there. I think if we go back more than 10 years or so, that's not how PTs were trained in school. And understanding sensitivity and specificity and likelihood ratios was an absolutely foreign concept. And, I think we were taught that, well, if you think it's this, you test it with that and this other thing, and if one of them is positive, that's what you have. And, we've come to understand that test clusters are good, and we've come to understand that, we can't make our exam up entirely out of special tests. And I think, that speaks back to your comment about your first year, and if you went back and looked at those notes, and I think many of us are in that same boat. But it's understanding which tests and which measures rule in or rule out which pathologies and how that shapes our reasoning, which is probably the third leg of the stool that we're going to address this weekend. Which tests have meaningful outcomes for these patients? Which ones tell us meaningful information to rule in or rule out the pathologies that we have in question?
With that answer, you've repetitively just, over and over and over said the words that come to my second point, which is clinical reasoning. Like the big linchpin here is, if you have all the right data, but you don't know how to think about it, then you can't get where you're going. And I know clinical reasoning is a huge topic. In my particular case, it took me years to get reasonably good at it. We're not going to, in a nice, neat little package here, present reasoning and this is how you do it, step 1, 2, and 3. But if you were to give maybe some generic advice to people that are looking at developing their clinical reasoning, what sources might they look at? What programs might they apply to? What's your general advice for that?
My general advice would be step 1 is learn something about how your brain works. So we have a very powerful processor, but it also has some major blind spots. It helped us during the evolutionary process in order to survive, but as a result, we often see something and attribute it to something that we did. So if we do something for the patient and they immediately get better, woohoo, it was something that I did. Or if I did something for the patient and they come back and they say they're better, we immediately attribute it to something that we did. So this is a fundamental problem with our processor. So correlation is not causation, and just because of something happens in time doesn't mean it's related to what we do. The other aspect of it is using abductive reasoning, which is the process of generating hypotheses. So you're starting by asking a question. You're not starting with a pre-planned answer. I know this is the answer. This is the system or thing or whatever that's the right answer right now. We're starting with a hypothesis. And then we modify our hypothesis using inductive reasoning, where we start collecting evidence and we start to change the probability of something being true as we collect more data. So early on, we're trying to rule out serious pathology. We're trying to rule out things by region. We're going through active paths. So we're trying to funnel and really refine. And then we're using those specific tests to try to put that cherry on the top. And now we think we really know what's going on. So that's when we try to test that hypothesis by matching an intervention to what we think is going on to see if they get better. And doing that within that process is a deductive linear framework. We're trying to connect our assessment to our diagnosis to our treatment, and our treatment to our outcome. And if we can put all of those types of reasoning together in the linear framework, we're creating an environment where we're more likely to be true or correct.
I'm going to take a great big step back and a deep breath and say, I think one of the first statements we had in this podcast was, the patient can't be wrong. And I think our first step in clinical reasoning has to be to truly consider the patient picture and really think about what their symptoms are telling us and not try to force them into some prepackaged model. And I think that's one of the places where development of clinical reasoning can go really right or really wrong. And if we take the time to truly understand the patient factors and what we're seeing and hearing, then I think we're going to be well on our way. I think to address your second half of that question, what would we recommend? I think the most valuable thing out there is good mentoring. And good clinical mentoring from individuals who, don't have a set of cubbies with generic exercises and who don't do the same exercises for every pathology. And just because it's a cervical radiculopathy, they all do chin tucks and hot packs. It's going to be somebody who thinks while they work, who continually reassesses their work, can explain their thoughts to you in a meaningful way that makes logical, biomechanical, physiologic sense. And we have to apply our background knowledge to understand the changes we're seeing. And I think if you can put yourself in a situation where you have a mentor who is able to walk you through those steps and also able to get you to step back and articulate what's going on in your head, because I think, Dr. Riley made a great point about understanding our own process. And I'll say, having worked now with, postgrads and residents for the past few years, one of the hardest things to do is to get the process out of their head into words to understand how they got from A to W when they were supposed to stop at C, and say, really, how did we get there? And, what were the steps and what were the stages and what were the thoughts? And, taking the time to really articulate that is, I think, incredibly important in the development of clinical reasoning, particularly for the younger clinician.
And I don't want us to forget about the metacognitive process. We've all been there. We've gone through and have done things, and you go, "Oh boy, that didn't go the way I planned on it going." And but being that person that steps back and says, "Boy, I really need to do that better next time. What went well? What didn't go well? How will I approach this different?" And that could be from a technical aspect, how we interacted with the patient, any number of different things. But it's that reflective process that helps you evolve as a clinician.
Yeah, I couldn't agree more, and that very much reflects my experiences, which is not surprising. And having mentored, graduates, they have their license, they're practicing, they're proud of their status as a clinical doctor. And initially, sometimes they seem a little bit annoyed that I want to talk so much, walk through the process, how'd you get here? What were you thinking about? And then pretty consistently later in the process, people say, you know what? Talking about the reasoning is the most helpful part. techniques are good, but if you can't implement them with purpose and utility and at the right time, it just doesn't go where it should.
Within that process, if it's always a big challenge while we're mentoring, but we really have to slow ourselves down. We have a habit of moving faster than we should, but slowing ourselves down, clearly articulate what we're doing, when we're doing, why we're doing it, and model that behavior. And then once it shifts to the student, have them do the same thing. If they don't clearly articulate what they're doing as they go through the process, because it is a process, then you can't recognize and or correct, modify, change, or, hey, have you thought about that?
I think that also, you kind of struck on one of the things that we see frequently, in that very often early on, therapists go out and they want to be technique collectors. I need a technique for, or I need something else to use for this, because they're really not fully grasping what they're working on. And, I think when we have a better understanding of the actual processes at hand, it's not that we need more tools. I've got a garage full of tools. I love tools. And, sometimes you need more, but more often than not with, our physical therapy patients, we don't need a lot more tools. The 6 thoracic spine manipulations I know are enough. I don't need a 7th. It's not going to be the miracle treatment for everybody through the door who has this presentation, based on the reasoning. And, I think the second side of it is we have to accept that, not all of us love to think about these things. And that's one of our biggest challenges. And, I recall clearly going to a course a number of years ago, and it was taught by Brad Jordan, who unfortunately is no longer with us, but it was about lumbar clinical reasoning and applying tests and techniques and measures. And, it was 2 days that really, kind of shook up my snow globe a little bit about how I thought about the lumbar spine. And I got to the end of the weekend, I was sitting next to a colleague, and I remember thinking that was the best 2-day course I've ever taken. And before I could say that, my colleague leaned over and goes, "Thank God that's over. That was the longest 2 days of my life. All we did was talk about thinking." And, if we're not ready to accept that we need to step back and think about our thinking, and if we're not ready to step back and have people challenge our paradigms and assumptions, then we're not ready to grow as clinicians. And I think that's one of our biggest barriers to growth, is the mindset to accept that we might be wrong and that other ideas might be beneficial to apply to our practice.
Those are wise words, and that sounds like a great place to end this conversation. But before we terminate the interview, can you provide some sort of email or contact list that people can reach out and talk to you in case they have any questions about this type of content?
Absolutely. I'd be happy to talk to any of our listeners who are interested in hearing more, or want to have a more in-depth conversation, or want to throw some rotten tomatoes my way. My email is bswanson@Hartford, HARTFORD.edu.
And my email address is Riley, RILEYS, 4, @sacredheart.edu.
Excellent, gentlemen. I will link to both of those in the show notes. And as I said before, it's been great having you here.
Thank you for having us.
Thank you, Steve.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.